There we go. Thank you very much. My name is Michele McCreadie. I'm the General Manager interRAI Services and I work for TAS, one of the Health Shared Services agencies. And today I'm going to talk about interRAI and where interRAI data comes alive. So I'm particularly focusing today on our publicly available data, the data that you can see, anyone can see on the website that's available for all. But for those who know nothing about interRAI, I will do that little bit of explanation at the beginning so you do know what I'm talking about. So we'll start with what is interRAI? People always ask, what is interRAI? And they always ask, well, what does interRAI stand for? Well, it stands for International Resident Assessment Instrument. That's what RAI stands for. And interRAI is really a comprehensive clinical assessment instrument. It replaces a battery of assessments that may have been done in the past and pulls them all together into one comprehensive assessment process. It's a best practice approach to assessing people's needs. It's standardised and designed for specific groups. interRAI is very applicable to vulnerable groups in society. There are about 30 interRAI tools that you can access that range from young people, very, very young people, through to old people, mental health, intellectual disability, those sorts of vulnerable groups. That's when interRAI applies at its best. It's standardised. So it's standardised in a way that it's the same for everybody. It brings an assessment process into a common language, common measures and common clinical concepts. So everybody speaks the same language and everybody understands the assessment in the same way. Here in New Zealand, we use 5 of those 30 different assessment tools, and we use them to assess the needs of older people. So any older person who is being provided with services in their home or is moving into aged residential care and they're receiving publicly funded services. interRAI is the prime assessment tool for those people. And in home care, we've been using it since 2007. And in aged residential care, we've been using it since 2011. And in 2015, it became, well, we call it mandatory. It's actually contractually required in aged residential care for people to do it. And in home care, all the 20 DHBs agreed that this would be their prime assessment tool for older people. So consequently, we've got an awful lot of data now, a huge volume of data about the needs of older people. That's the picture in terms of contact assessments, which is a simple screening assessment that basically tells you, do I need to do a bigger, more complex assessment on this person? There are some needs here. Do I need to address them or do I need to investigate them more? Home care assessments, about 37,000 a year, and long-term care facility assessments, so assessments in aged residential care, over 70,000 a year. So we get about 127,000 assessments per year. They come into the database, into our data warehouse, and we've got over 500,000 assessments of older people in the data warehouse. So in terms of what that means, about 13% of the older people, so 13% of those over 65 in New Zealand, and 42% of those over 85 in New Zealand. So a very comprehensive picture of those older people's needs. So what does interRAI tell us? What does it actually tell us about that population, that growing older population, the one that we're all going to be in at some point before very long? That, I think they can refer to it as the tsunami of older people. So interRAI basically tells us 2 things. There are 2 main outputs from the assessment process. It gives us outcomes. Outcomes show a picture of the person's needs, their clinical and their functional status, so how they are now, that outcome now. And a higher score normally means that there's higher urgency or there's greater need. The other output from an interRAI assessment is what's called a CAP, clinical assessment protocols. And clinical assessment protocols are triggered. They're triggered when there's an opportunity to make a change, to either improve the person's situation, to slow the rate of decline or help symptoms. So they're not always triggered in all cases because there has to be an opportunity for something to happen. It's not an immediate thing. It's triggered, and it's triggered by the algorithms that are part of the interRAI assessment process. So the algorithms trigger and create a picture of the outcomes and the CAPs, and then from that the care plan is created for the older people. Usually it focuses on the CAPs, and it should focus on where you can make a difference, where we can be effective, and where something will actually happen. Now, if you really want to know more about it, there's a very nice, simple, straightforward picture on our website. There's a video that'll tell you that. In about 2 minutes, it does it for you. So we have just a quick example of a clinical assessment protocol. So one that's very commonly used is what's called the falls cap. So it's an example. Falls are obviously very common in older people. And the falls cap shows you the risk of someone falling. At level 1, that's the blue one, it will trigger when there's been one single previous fall, and level 2, multiple previous falls. So the higher the score, the higher the urgency, the higher the need to address it in the care plan. So it gives you a picture. That's just a nice example. It also gives us a very comprehensive picture of the older people. So it's not just about their physical and functional status, it's about their social well-being. And this picture shows you loneliness by District Health Board. So there's a question in the assessment about loneliness, and then we can produce that information, as I'll talk a bit later, at all levels. But this is just a quick picture of loneliness across the District Health Boards, and it's the Wairarapa for some reason that I not entirely understand, but it's one that stands up high, and it's triggered very frequently. So it's a question that shows very frequently in the Wairarapa DHB. But there's been a lot of research recently about the impact of social isolation and loneliness and the impact that that has on older people's physical health and well-being. So how does interRAI data add value? Well, the primary purpose of an interRAI assessment is to understand that older person, to understand their needs, to fully understand their needs in one assessment, and then be provided with the information that supports the clinician to make a decision about the care plan. So that's the prime reason. Primarily, it's about that individual person. That was the reason for introducing it. However, it brings many other things with it, because you collect that information once and then you can use it many times in many different ways. So the important premise, we only collect it once and we collect it in one assessment to then produce an awful lot of information used elsewhere. So you can use it when you're looking at service development, you can use it when you're looking at policy development, either at a local level or at a national level. You can use it to look at quality standards. I'll talk a little bit about that later. You can use it for research, and it's widely used for research. So we collect it once and use it many times in different ways. And we have that information at all different levels. So obviously we have the information about the individual client, and that's available to an assessor. We have the information at a provider, either a home care provider or an aged care provider facility level. That would be available to the facility manager or the provider of that service. We have the information at DHB level. You can gather that up into regional level. You can gather that up into national level. And we also have a responsibility, because interRAI is an international tool used in 35 different countries. And part of our royalty-free license in using interRAI is that we have to report at international level, so we can also compare our data to the other countries that are using similar tools. interRAI data is used a lot, as I said, in research. Most recently, about this time last year, there was a research released on the impact of loneliness and socialisation on the outcomes in older people, and it's particularly whether it was a predictor of someone moving into aged residential care. Very recently, there was a research published in New Zealand on drug burden index and its relationship to hip fractures. And that one said, and I have to say this because we were so proud of this line, it says, New Zealand's world-leading data set on the elderly called interRAI made this study possible. So we were kind of thought that was a good one, but a lot of research using it, and there's a lot of international research. You can also use interRAI in a different way, and we've just recently started to gather information to develop what we call quality indicators. Quality indicators are the first time that we've used interRAI data to talk about service delivery. So instead of always talking about the needs of the older person, now we can talk about the services that are delivered to those older people using the data that comes from interRAI and developing quality indicators. This is quite new. We've just started to do that. We started looking at how we can do it, and we've published our first national pictures. we've published information to large aged care providers. We're only doing it in the aged care facilities at the moment. We'll work towards doing it in home care a bit later. And we're about to move to a process where we'll risk adjust the information, and then we'll be able to provide it to smaller aged care providers, because we need to risk adjust before that, or otherwise there'll be obvious who's who. This is all provided down a secure channel at the moment, and we had to get to sufficient volume of data before we were able to do that. So that's provided to in a secure channel, so you can see you, but you can't see who everybody else is. Okay, so it's done that way at the moment. But what we have got is publicly available data for anyone to look at. It's on the interRAI New Zealand website, and our data is visualised on that website. So we've got lots and lots of information, and we've made it publicly available to anyone who wishes to look at it. Obviously, it's de-identified, and it goes down to DHB level. We don't identify providers or individuals in that, and we use Power BI for that data visualisation. So it gives you information about assessments, about the counts. The counts are in assessments, not people at the moment. It gives you aggregated data. It gives you the outcomes, and it gives you the clinical assessment protocols aggregated however you wish to look at them. And it gives you demographics and social well-being measures. That's the link. I'm not going to attempt to go into the link because it probably won't work very well in here, so I'm just going to use the screenshots. So this is a summary of the national picture of our data visualised. Shows you the percentage of the population that's been assessed, gives you the most commonly diagnosed diseases and a volume of assessments. That would be a starting point. Gives you demographics. So here's the demographics by type of assessment, by ethnicity, by age band, and by gender. And just for your information, the median age for a contact assessment is 81. The median age for home care assessments 83, and the median age for a long-term care facilities assessment is 85. So we're in the older, more vulnerable end of that older people's picture. It gives you the information by disease diagnosis, and you can manipulate that. You can look at it by type of assessment, by age, by gender, by ethnicity, by DHB. And you can pick your different variables that you want to look at, and you can choose how you want to use that information on the website, publicly there for you. It also gives you the social well-being measures, some of the social well-being, well, most of the social well-being measures. So this one in particular is about enduring power of attorney. So one of the questions in the interRAI assessment is, do you have an enduring power of attorney? Has that been enacted? This gives you a picture by ethnicity. We just chose to do it by ethnicity of enduring power of attorney, but you could do it by any of the variables that are available in the system. So there's essentially a wealth of information about older people's services there for you to use, and it's basically for you to use, via your mouse. Your choice, what you want to look at. So where are we going next? So we launched the visualization about 10 months ago, and now we're looking at where we go from here. What's the next phase? So first of all, we looked internally at how we designed it and was it working? And then we've done quite a comprehensive look at what the user's experience is of the data visualization, and is it doing what we want it to? Is it providing people with the information that they're looking for? And we did a survey, and we did some qualitative interviews to get that information. And basically they told us there's some priorities for where we might want to go. People want to be able to, the ability to print and download. At the moment you can screenshot, and people use those screenshots often in their reports and within the DHBs, or if they're presenting they use the screenshots, but they don't always come up that well, so people would like to be able to print and download. We need to do a bit more training to help people find their way around, and a bit more explanation of interRAI methodology and interRAI terminology, so people are very clear what they're looking at. But the main thing that we heard was that people want actionable information, which I think means they want us to not just give them the information and help them to find their way around it, but also say what you should do about this and what it's telling you. So that's another step for us to take, and one that we hope to do when we launch the phase 2 of our information. So away you go. That's me. Thank you.
Well caught. Hey, question for Jonathan and Monique. How many business analysts do you have supporting the clinicians with your Click implementation? Because I imagine that there'd be quite a huge demand once it became available.
We currently have 2 full-time analysts and sort of another 2 part-time analysts supporting clinicians. But as you say, there is a long waiting list because there's a lot of demand for the data.
And I mean, one of the things with Click is that it does empower sort of end users or people with a little bit of technical expertise with a lot of tutelage by Monique to sort of build their own apps and that sort of thing. So you know, each analyst can create a huge amount of useful content, but now that's becoming more well known and more successful, we're starting to get, I guess, more demand for that core work that they do. Yeah, but it's money well spent, I'd say. Yeah.
And a separate question, seeing as I'm hogging the mic.
Right.
Hey, how difficult would it be to pull information in, say, from the interRAI system into Click so that I can look at outcomes post-anaesthetic?
So interRAI has a data access request process. If you want to request interRAI data, you can go to the website, complete the form and request interRAI data. If you want NHI identifiable, we have a system with the where we can give you that information and we can encrypt it and so on, and then people do use it to match it to other databases using the NHI.
Thank you. You just need enough information to allow that matching up to occur, basically. Yeah, the more the better. Sure.
Gus from Wellington Free Ambulance. Just another query about Click. We use ClickSense. Just about Click. What made you choose that over and above other products like Power BI? I know this produces reasonably similar type of look.
It was probably a long process. I wasn't personally involved in it. I sort of came in after the fact, so I probably can't speak to that too much, but it was a pretty detailed evaluation, as you can imagine. I think there are a few products out there. I know this one works really, really well for us. But yeah, that's about as much as I can speak to. Maybe Delwyn could. Do you want to? Or yeah, I mean, there's.
We shortlisted Tableau and Click. A lot of it comes down to the third-party vendor who's going to help you put that in, and we worked with Acumen, so that was all part of that bid. So that was really important. We had presentations and Click won. So we had a panel. So yeah, and we also liked the way that we could pull data from a lot of different environments into Click, whereas I think with Power BI we were more limited. So no, you wouldn't say so? No. Anything? Okay, sure. I think probably I'd have to say that, yeah, the presentations and that third-party vendor who was helping us do it really probably tipped Click over the edge. Does pretty well up the Gartner quadrant.
Thank you.
No worries.
And I have a question for you, Kay, and that is, you made a couple of comments in your slide presentation. Vast pools of data are available, and also people ask, what do we want to know? My thought is, once people understand the data available, how do the questions they ask then change?
Thank you. I think, yeah, I might have ventured into this area as well too. So I ask a simple question to begin with, I find out the answer, then I start to ask more complex questions and go through that way. And that's where the benefits of these visualization tools, and whether it be Click, whether it be Tableau, whether it be Power BI, they essentially tend to work the same. And it's presenting that data in a way that's meaningful to answer questions, and that means it can evolve over time as well. And I think that's where the tools that we have available to us now allow us to tweak how we present things. I think we even saw some of the filters and things that you can actually display, change the way the data is viewed even before you drill down to the underlying detail. But it's yeah, just endless from that side of things. I think a lot of people that enjoy their data can just get lost in it.
Hi, I've got a question for Kay as well. You had a few slides on loneliness, and I was wondering if there'd been any international comparisons of loneliness and how we compare on the interRAI data.
No, we haven't done any international comparisons specifically on loneliness, but there has been a lot of research on loneliness across, particularly across the Western world, and it has been released. But I haven't got an international comparison of loneliness in New Zealand to loneliness in Canada or anywhere. We can do it within New Zealand, as you can say, by DHB or region, etc. There's also I didn't show it, but there's a specific clinical assessment protocol called social isolation, which sits alongside the question around loneliness, and you get a very similar picture across the DHBs for the social isolation cap.
I have an additional question actually for Jonathan and Monique. And one of the things is, it all looks so incredibly easy. And Jonathan, you mentioned you spent a number of months trying to do it yourself. When it came to engaging with the Click team, how difficult or not was it to identify where all the data was across the data warehouse? And was it in a state that was usable straight away, or was there a level of cleansing that was needed?
Well, in terms of our data warehouse, we're very fortunate at Waitemata that we have a very good data warehouse. We've just recently moved on to a new Westcape Red warehouse, and I don't think we by any stretch of the imagination have access to all the data in the DHB, but we have access to a large chunk of it. And the great thing about Click is that if you do have additional data sources, it's really easy to link them in and get access to that data against your data warehouse as well.
Yeah, and I mean, that's the thing. For the ICU, luckily, we had that data already there. The trend care and the IPM data was already there, all packaged up, and I could just jump in and build the app based off those extracts. And that's the beauty of the Power BI and Click and all those other type of systems. The months I was referring to before was more about me trying to do it manually with Excel, which was very painful. So I decided to work with Meek and build the Click app instead, and that worked very well. Sometimes you do, even in areas like building apps for anesthesia, the safe sleep data wasn't actually used by anyone else because, well, no one else really needs it most of the time. But to actually do those extracts, in other words, get the data from the source, is actually pretty straightforward because of the way the data warehouse is set up. So even if the Click package isn't there, you can actually create one without too much trouble. But it's really important to have that relationship between the IT people and clinicians, so they can explain to us some of the important data concepts, and we can explain why some of the clinical bits are important and why that field's important and how to interpret it. And of course, you can do that interpretation as the data comes in if you want, which is extremely useful because again, that's available for everyone else as well. The building of the model is initially it takes a lot of work, but once that's done, I think you're able to then leverage off that. Yeah. And of course, the time you save down the track is phenomenal. Yeah.
Just a quick question. You've talked about how hard it is to direct action to see the same thing in different places. How are you getting on with implementing SNOMED, guys?
Oh,
You,
we haven't gone there yet.
you
But
need to.
we know we need
You need to.
I guess, we've got a number of clients that are already using SNOMED, and SNOMED is most often used as the terminology reference for any clinical decision support these days as well. So there are a number of mappings out there which are sometimes better and sometimes not as good as they are, but it's important with any of these things, I think, to determine what is your point of reference and use that as the sort of source of truth, if you like, and then map other data to it as well. And it would depend which was, I guess, your predominant vocabulary or terminology that was being used across the data set that you've got.
thank you. Just as a hint, I would suggest to you that any IT business case that comes to the Ministry will not progress if it's not mentioning snowmen somewhere.
Yes, yeah, and I'm obviously the accent. I'm based in Australia, and it's the common use now as well.
Just to Jonathan, obviously you're a clinician yourself, but one of the problems a lot of people have is clinician buy-in on their IT projects.
Yep.
What's the key in getting clinicians bought in?
I think, because I had to do this a lot with the ICU, they tried for many years to get business cases across the line and with some difficulty. And obviously, the environment's quite challenging at the best of times. The thing is really to just talk to them and understand their problems, find some people that you sort of resonate with on a sort of philosophical level and get some early adopters and go from there. And that's been really one of the keys, because then they can spread the word amongst their colleagues as well. If you're coming in, I'd worked in the ICU, so I knew everyone there, but I still had a bit of an operational hat on, whereas I worked with a colleague who could then sort of spread the word and just, get people on board. It's just steps at a time, I think. It's just a slow process. I think the main important thing is to realise it does take a lot of time. And really, I think just take a small bite of the pie and find something that's really easy to demonstrate, that's convincing, that has that level of granularity and that context that people get. So they know that you're not just sort of responding to some KPI and saying do something. You're actually saying, well, take the anaesthetic, the normothermia thing, for example, that we're doing. You could actually not just show what the patient's temperatures are, you can say what theatres they came from. And one of the specialties is colder than the other, let's say. And that context gets buy-in, and you go from there. So it's a slow process, but yeah, I think it's just about finding some early adopters and finding something that resonates with them. Yeah. You'll still get the range of responses that you might get from clinicians, and me being one. I've done that in the past as well. But that's just part of the process. I learned to just let that sort of, I do the old sort of, let it wash off. Yeah.
Great, well, thank you very much, and can we please have a round of applause for our presenters? Thank you for your participation and